There are some great politicians in California, some people who bring real passion to the work. Holly Mitchell is certainly one of those. You know, she set the stage to talk about homelessness and some of the state policies. My job is to introduce Dr. Joshua Bamberger. You all have his bio in your program. You can see all of the many accolades he has, the different positions that he's had. Just two things I want to frame about him. He's really been working at the intersection of homelessness and healthcare in San Francisco for a long time, and leading a conversation, pushing those two systems together, pushing the housing system and pushing the healthcare system closer together in San Francisco, in the state of California, and at the national level as well. As I think about our work at Housing California, there is so much opportunity at the intersection between homelessness, between housing, and between the healthcare system. That community development, that the tools that we bring to the table can really dramatically improve people's health and can lower healthcare costs. Has started in the world of homelessness. It's really a sweet spot also in thinking about seniors who are living in skilled nursing facilities who shouldn't be there. But I think that we can take those sweet spots and also expand to think about communities that are driving healthcare costs because they don't have the opportunities that they should. So I'm going to invite up Dr. Bamberger to talk to us today and to walk us through the work that he's been doing.
Good afternoon. This is freaking me out. There are so many of you here. Let's see, I got my beta blocker, I got my Fitbit on. It says my heart rate's only 65, so I'm doing all right. Whew. Thank you so much for inviting me to this. I feel like I don't really know if I deserve to be talking to such an incredible, powerful group of people who can change so much and who are working to serve and provide housing for people I've been trying to care for the last 26 years. So I've only been a homeless doctor. That's all I've ever done. I've tried a couple times to work in the private sector, and I just keep getting sucked back because it doesn't feel like it's the right set of clothes. So let's see if I can get this up. Great. So in thinking about today's presentation, I was listening to NPR, and they were talking about how it's the 75th anniversary of the Four Freedoms State of the Union speech by FDR in January of 1941. Now, the Four Freedoms are pretty great, I think. And when I was thinking about this in my own family, I was thinking in January 1941, my father, who at that point in his life was named Klaus, was living in a boarding school in England because he had escaped Nazi Germany the day after Kristallnacht in 1938. And he was trying to come to this country. An interesting parallel to Senator Mitchell's family is that because my grandfather happened to run into a cousin of his in a hotel in Paris in 1938, he found that he had a distant uncle who was the governor of Utah, Simon Bamberger. Simon Bamberger was the governor of Utah from 1917 to 1921, the only non-Mormon governor in the history of the state. And he allowed and sponsored my family to get a visa to come to this country. And they arrived in July of 1941. And when my father arrived here in this country with the name of Klaus, he changed his name to Frank in honor of Franklin Delano Roosevelt, and in part because of these four freedoms. And when I think about what I do as a physician and all the things that all the medications I can prescribe, nothing gets to these things: the freedom of speech, the freedom of worship, the freedom from fear, and in many ways, the most important thing, the freedom from want. You have this ability to provide my patients the opportunity to have these things, because housing is the key to achieve these things. Nothing I do in medicine is able to change the mortality curve of the population I've been serving for 26 years, except housing. And this is what everyone deserves. It should be human right to have these things. And this was about foreign policy, but it really has to do with serving people who have no voice. $2,645. When I looked on Craigslist yesterday, that was the The rent for the lowest studio apartment I could find in San Francisco on Craigslist. So you guys from Brilliant Corners, you might be able to find some cheaper, but this is what it says on Craigslist. Now, for a homeless person in San Francisco who may be getting their sole income from Social Security, about $930 a month, there is no fantasy, nothing in the magic kingdom that will ever allow them to afford that rent. Ever. So unless, as Senator Mitchell said, we want to live in a city where there's just basically a homogeneous, rich population, unless we want to have some diversity of income and race, ethnicity, we have to do something to try to bridge the gap between the cost to live in the city of San Francisco and many of the cities that you come from. We have to do something, and that means figuring out a way to use government expenditure to bridge that gap, and that's what we're here to talk about. 10% to 70%. Now I get to switch my hat a little bit and talk about healthcare. In any healthcare system you see, about 10% of the people use 70% of the healthcare resources. And yet everything I do in my clinic around hemoglobin A1Cs and colonoscopies and vaccinations really is trying to serve the 30% of the people, or the 90% of the people that are using 30% of the resources. We almost do nothing to serve the highest users, the hotspotters, the super utilizers. And housing is the key to reduce those healthcare costs and improve outcomes. Targeting. If I leave you with one thought today, I want you to embrace the fact that the homeless population is an exceedingly heterogeneous group, and that almost everyone who dips their toe in the puddle of homelessness will be able to leave or does leave homelessness without government expenditure. The big mistake we've made in San Francisco is when someone comes to the honeypot of housing, we offer them that housing and they're in it for the rest of their lives being paid for by government expenditure. We need to find a way to target the limited resources we have towards the people who are sick. Now, that may rub some of you the wrong way in the affordable housing sector, and it should. Because your job is to expand resources for all people who are low income to get to housing as a human right. My job is to take care of sick people. And from the healthcare sector, what we need to do is have the courage to say that if we're going to get access to housing as a healthcare treatment, we must use it for the people who are sick. And we actually have to deny it to people who are not. Not because it's the right thing to do, but because we have to make incremental change to use what limited resources we have. Now, 18% of the gross domestic product in the United States goes towards healthcare, the second largest industry behind defense. Why do we go to the healthcare sector to find money for housing? Because that's where the money is. But we have to convince the healthcare sector that we can use it wisely, and that we can use it responsibly, and we can use it for the people who are sick. So in every place you go back to, whether Fresno or into Kern County or to Los Angeles, we need to continue to have the courage to say, if we're going to dip our ladle in the bucket of healthcare financing, we must drink that water only for the folks who are sick. And that is often a very hard conversation. For example, this is a picture of a patient of mine who has 5 admission bans on his wrists. He went to so many different emergency rooms and was hospitalized so many times, and then he would leave, he had to go use crack, and he'd go out to the streets. And the only way I was going to get him to stop using healthcare resources unnecessarily, to not improve his health, was to house him. These are the people we need to target with our healthcare dollars. So today, I'm just going to talk about 4 questions. It's going to feel like you're at Passover Seder, but that's okay. My kids tell me not to do that joke. They say, no one gets that around here. Anyway, so here are the 4 questions. And I'm not going to answer them for you. I'm hopefully you're going to answer them for yourself. So does housing improve the health of homeless adults? Does housing reduce cost for high users or super utilizers of the healthcare system? Can, within the existing structure that the healthcare delivery system works, or are there examples of the healthcare system paying directly for housing subsidies, development costs? Is that done? And if so, how and where? And should the healthcare system? And this, to me, is the most important thing, because what changes policy? It's not so much cost. I really don't believe that people show up across the street at the state capitol because they want to reduce the cost of the state government. I don't think that's why they get up in the morning. I think we do this because we are trying to take care of each other. And should healthcare dollars be used for housing is a question I hope you can answer at the end of this talk. So first question, does housing improve the health of homeless people? Duh. I mean, how many people have seen someone living on the streets and think they're in good health? It's so hard to live on the streets and be healthy. But we can say that and believe it and know it in our gut, but is there data to support that healthcare can improve the health, housing can improve the health of homeless people? And before I answer that question, I'm going to show you a slide that came from nothing to do with housing. This is a slide of a study that was done on a new anti-cancer medication that was developed by Genentech, south of San Francisco. And this medicine is called Avastin. Some of you may have taken it, and some of you are probably alive today because of this medicine, or so you believe that it's the medicine that made the difference. In this study, this is what's called a Kaplan-Meier survival curve. Don't freak out. And it shows that if people are randomized to a drug called Avastin or not, they have a difference in survival. And the people who were randomized to the treatment arm of this study had a 74% chance of being alive with their colon cancer after 1 year. And after 2 years, they had a 45% chance of being alive. And if they were randomized to the placebo arm, they had a 63% chance of being alive after 1 year and a 35% chance of being alive after 2 years. Pretty bad, right? Even at the treatment arm, you have less than a 50% chance of being alive after 2 years. Now, when these data were presented at the 2005 oncology meeting, the entire 2,000-person audience stood up and gave a standing ovation. This was the best result of an anti-cancer agent ever produced in this country for a bad cancer. We did a similar study, this is another Kaplan-Meier curve, in another population that has a very high mortality rate, but instead of treating them with medication, we were treating them with something else. In this study, there were 683 people in San Francisco who at the time of their AIDS diagnosis were homeless. This was between 1996 and 2003. During that time, access to antiretroviral treatment was available to all San Franciscans as it is today. And yet the people who were not housed in our particular brand of permanent supportive housing in San Francisco called direct access to housing, they had a likelihood of being alive in 1 in 4. 25% of the people after 5 years were still alive despite having access to treatment. And this survival curve is the same as the survival curve when I first started practicing medicine in 1989, when we had no antiretroviral treatment. So in this study among people who were homeless at the time of their AIDS diagnosis, the medications were insufficient to change their mortality curve. But the group of people who were 77 who happened to get housed in our housing, this is a retrospective study, the 77 people who were housed in our housing, only 2 of them died over that same period. So there's a huge gap in the Kaplan-Meier curve that blows Avastin away. It is so much more effective in changing and bending the mortality curve. Housing is so much more effective in bending the mortality curve than anything that I can write with my prescription pad. And yet we don't buy it like we do with pharmaceuticals. Why is that? Why is it that we have a system in this country that is absolutely ready to spend $1,000 a pill for a new hepatitis C treatment, but we will not spend the $1,200 a month to house somebody with healthcare dollars? What is the difference? How did this happen? And it's so much, it's just, there's no real answer to my rhetorical question, except the definition of what is healthcare. We in healthcare don't think that housing, what you have, what you've worked your lives, your careers to develop, is something that we should have and that we should pay for. We could easily. There's plenty of money in that 18% of the gross domestic product to pay for housing. But we don't, because we have defined housing as something that is not a healthcare treatment. Even though the data shows that there's nothing I can do in my career that can improve the health of the people I serve more than what you have. Why is that? And how can we change the words so that housing is healthcare? How can we convince pharmaceutical companies to embrace housing as another treatment they have, or managed care organizations, or governments? What is it that changes the words? Words matter. And saying wherever you go that housing is a healthcare treatment, who will ever sit still long enough for you to tell them a story, tell them that story, and words can change policy. And yet, it's not just any type of housing that makes a difference. This is a study that's not nearly as scientific as the previous study, but one that's my favorite of all. This is a study that looked at the mortality across 13 buildings in San Francisco that I control access to, and looked at the quality of the housing correlated with the survival. And it's very unscientific. It's the Joshua Bamberger scale of beauty, and it goes from the Windsor Hotel, which looks like this one, which is a SRO in the Tenderloin, to Plaza, which is a first affordable development that we did targeting exclusively chronically homeless adults in San Francisco, to Mission Creek, which is owned by Mercy Housing, which is another place I work for, and it's beautiful housing, and we're really proud of this work. And what's so cool about this picture is it shows around Mission Creek, which houses 53 chronically homeless seniors in addition to 100 low-income people through Section 8, it shows that around is the $1 million studio apartments that everyone knows about in San Francisco. But what's so great about Mission Creek is that the health of the people who are living in Mission Creek is probably improved by being around people who have more means, and remarkably, the data shows us that the people who have more means have better health because they're around a more diverse community. So every study of public health I've ever done has shown that the diversity improves health outcomes for all people who participate. And this picture shows that really nicely. So anywho, here we go back to this survival curve, and what we see is that the more beautiful the building, the less people die. Right? Statistically correlated. What's going on in what you do out there every day to make beautiful housing that makes someone who comes into Mission Creek with stage 4 colon cancer survive for 15 years? While if that same person is placed at the Windsor, they die after 7 or 3 or 2. This is not an illness that is easy to treat, right? People who we're placing in these housing are sick. What is it about what you do that changes the survival among people who are housed there? Where is that magic? What is that hormone, that stress reducer? What makes people live longer because of beauty? And I really don't think there's an easy answer that comes in medicine or in science. I think it comes in poetry and music. It's the feeling you get when you climb to the top of a mountain and see a sunrise. That's what makes life worth living, and that's why we live. It matters how beautiful the housing is. And it turns out it not just matters because it's the right thing to do and we can, it's because it actually can do more for the health of somebody than anything I've got in my training. So does housing superutilizers reduce cost? You know, anything you do in medicine costs money. Of all the things that I've done in my career, the only thing that I have to show reduces cost is housing. If I have a new treatment, it's more expensive. You still got to pay $1,000 a pill for your Hep C treatment. The money is spent more, and Centers for Medicaid and Medicare pays for it. But with housing, we have this incredible standard. First of all, we don't call it healthcare, and then we have to show that it reduces costs, but thankfully it does. In one study, there's the largest study of permanent supportive housing in North America, was done in Canada, so of course it doesn't really exist because it can't really be valid if it's done in Canada because they're so different than we are. I mean, they have, after all, a prime minister that has a big raven tattooed on his back right now. But that study looked at 6,000 people, and they randomized them to housing versus regular care, and for every dollar that was spent in housing reduced healthcare costs by $2.50. Now, if this were Apple stock, people would be buying it hand over fist. This is a tremendous return on investment, much better than anything you can get in the private sector, but yet we haven't figured out a way to get money into the sector to get that return on investment. And that's why I think we're at an incredible time right now, because you people, as they say in Boston, are wicked smart. And I know you can figure this out. You've got to figure out how to capture this savings so that the healthcare sector, which is drowning in expanded costs, can minimize its expansion. We have this answer. We can make this happen. I did a study at Mission Creek where we found that $29,000 in healthcare costs were reduced for the year after somebody moved indoors per person. $29,000. The cost for the city to provide the local operating subsidy and the wraparound service is about $12,000 per person. So that's a huge return on investment as well. And even at Windsor Hotel, which isn't so beautiful, but it's still nice, it's still housing, we had a $19,000 reduction in healthcare costs. Now, when I've done these studies, and I've done a lot of them, no one believes them again. Again, it's this level of scrutiny and suspicion that is different than anything else, right? I mean, you get like a $1 cost saving from a vaccine. It's like the greatest thing in the world. But if it's housing, then you have to prove it over and over again. And you say, well, this wouldn't have been a true study if you had a control group. Because if you had people who are in a randomized control trial of housing, actually the people who are really expensive would get cheap anyway, just by, hanging out. They didn't need to be housed. They could stay sleeping on a heating grate and they'd still get healthy. So you have to have some way to counteract this concern about what's called regression to the mean. So even though I think it is probably unethical to do a randomized trial of housing, knowing fully well that housing is better than being on the streets, we did a randomized trial of permanent supportive housing. And we're in our third year, and I'm going to give you some very up-to-date data on that study. So this was a study where we went to all the people who are seniors and persons of disability enrolled in the San Francisco Health Plan, which is the Medi-Cal managed care program of San Francisco. We found 30,000 of these people. This is before the Affordable Care Act rolled out. And we looked through their entire database until we could find 180 people who we were pretty sure were homeless and were also high utilizers of the healthcare system, with the bar only being about $3,000 of healthcare costs annually. Then we randomized them, where we started the most expensive person at the top and the least expensive person over $3,000 on the bottom. We went 1, 2, 1, 2, 1, 2, 1, 2, 1, 2. The ones got offered housing. The twos did not. And we went out with case managers and outreach workers and found all the people who happened to get that Willy Wonka gold card for the tour of the candy factory. And we knocked on their cardboard boxes, and we said, guess what? You're moving into Kelly Cullen Community, a beautiful, brand new $94 million renovation of the old YMCA built in 1906. And we found 54 people who we offered housing to, and 50 of them moved in. So that myth that people don't want to be off the streets is a myth that we can easily dispel with beautiful housing. If you offer someone, a shelter or a crappy SRO, then maybe they want to stay on the streets. But if you offer them KCC, they don't, at least not in this study. And we're following them now for the last 4 years. So the data I'm going to show to you is preliminary. We have a lot of sort of mathematical reorganizing to do, particularly since there are some people who have died in the study and we need to have some matching appropriately, but the study still is probably going to hold and it's quite valid. And here's the results of our first 2 years of the study. So if you look at the bar graph on the right, my right, your left, you'll see the group that's represented by who were housed. So there were 50, actually this is an intent to treat analysis, so actually we looked at all 90 people who were randomized, so even only 50 of these people were housed. It's all 90, so it's even a more robust study if anyone's out there who wants to be a statistician. Anyway, so they were $25,000 in healthcare costs the year before they moved indoors, and then the year after they moved indoors, they dropped to $12,000. Same study I've been doing for the last 10 years, right? The second year, they still maintain their low healthcare costs. So the intervention to reduce healthcare costs is sustainable in this study, at least over 2 years, okay? The most important part of this graph is not that, which we've done, as I've said many times, and you'll see it in Salt Lake and in Phoenix and Minneapolis and every other place that they're moving towards ending homelessness. You'll see the same marked reduction in healthcare costs when people move indoors. The most important part of this graph is that gold bar, or sort of brownish bar, in the middle of the control total. Because those are the people who we didn't house. And those are the people who, if we don't house, continue to be sick and very expensive. So if you want to make the case, and this is what I hope you will leave today doing, to make the case that what you have as housing developers can be a return on investment in the healthcare sector, look at that bar. It's either you pay it for the housing or you pay for the healthcare, and the healthcare doesn't do no good. Doesn't change the mortality curve. And then that gray bar is kind of interesting, isn't it? All of a sudden, these guys got less healthcare costs in the second year. The control group did. Why do you think that is? So, someone up front said they found housing. That's true. What else happened? So 18 of the 90 who were randomized to the control group, probably unethically, died. And because we're out there trying to find the sick people in the streets of San Francisco and offer them permanent supportive housing, we're doing the best we can to prioritize our housing. 41 of them were housed. So if you look at the reason why the healthcare costs went down in year 2 is because they got sick enough to finally come to our attention and we housed them. Again, it proves the point that if you house people, it's less expensive than to leave them on the streets. You've got that, and the healthcare sector is so much bigger than your sector. Go out and prove it to them. Now, are there these impediments to actually using healthcare dollars to pay for housing? And yes, there are some, but I really do believe that they are overcomable, and I'm going to show you some examples of where that has been done. So first I'm going to go to little San Mateo County, south of San Francisco, represented by this big wave, which is the Maverick surfing competition, which is off the coast of Half Moon Bay in San Mateo. Now this is a very unusual healthcare system, and I'm going to get into the weeds a little bit about healthcare strategies and policies, and I hope I don't freak you out too much. But the health plan of San Mateo is a small health plan, and it's the only Medi-Cal managed care program for the entire county. And they're a county-organized health system. So if you are poor and live in San Mateo, you are automatically in the health plan of San Mateo. You can't disenroll, you can't enroll somewhere else. They get all your capitated costs from the state. So every month, they get a check from the state for all the people who are poor in San Mateo who qualify for Medi-Cal. That puts them in a very flexible, opportunistic system. And the other thing is, they have a fee-for-service setup. So every time a homeless person in San Mateo County goes to Mills Peninsula Hospital with pneumonia, the health plan of San Mateo gets a bill for like $5,000 a day. And that hurts. So they have a strong negative motivation to reduce that exposure. Just like you guys are risk averse for the most part as an industry, the health system does not really like to have their capitated bucket sucked away by people who don't really need to go to the hospital who do. So that's 100% of the people enrolled. It's a fee-for-service, full risk system. Another thing they have is 6 different lines of business. Not only do they have Medi-Cal, they also have Medi-Cal and Medicare, and they have their CCI county so that they can actually capture savings and keep it, allowed by state law. So all these things lined up to one day when the CEO of the health plan of San Mateo got a call saying that their largest nursing home was going to close in 1 month. And they had to find placement for 400 people who they were paying $500 a day for nursing home care. And there was no nursing home capacity in the entire county. So instead of sending people out to Fresno and Oakland and everywhere else away from their families and friends, they went out and looked at all the people in the nursing home and they said, are there some people who could actually live somewhere else? And they found 20% of their entire nursing home population they felt could live in independent housing if they would pay for it. And they did. So they contracted with Brilliant Corners to be a housing intermediary. They contracted with the Institute on Aging to be the wraparound services. And they went out and they rented apartments all through the county. And they found residential care facilities who would take people out of nursing homes. And they moved them out of the nursing homes into places where we'd all be so much happier to live. Where we can have sex with whom we want to. We can eat what we want to. We can watch whatever movies we want. We don't have to live in these institutional environments. We can live and live longer and cheaper, much cheaper. And they just did it because they were bold and they were courageous. And nowhere else in the country have they used Medicaid dollars directly to pay for rental subsidies. So that's a fantastic example, and it can be replicated pretty much anywhere. And then getting back to Senator Mitchell's district in Los Angeles, it says Michael Jackson, a little blurry there, but I like that anyway. Los Angeles has done an amazing thing as well, and mostly with the leadership of Dr. Mitch Katz, who's the health director, is he realized that when the Affordable Care Act was going to roll out, he could capture a huge influx of federal funds. But the federal funds could not be used directly for rental subsidies development costs. So he wanted to figure out a way around that, and don't ever play chess with this guy because he will kick your ass. So he realized that with the enrollment of people who are now 60% of the people who are getting served by the health system in Los Angeles were uninsured. And on January 1st, 2013, they were all many of them were going to be insured. And he was going to get this $210 million of new federal state dollars into the county. And with that, he automatically enrolled them in their health system, got the capitated rate, and then went to the Board of Supervisors, and I can't imagine how this conversation would go, but somehow it worked out. He said, listen, I'm getting $210 million. It's actually your money, but how about you leave it in the health system instead of using it for potholes and police? And they said, okay, which is a remarkable political maneuver if you think about the big picture, right? And with that, he was able to supplant $210 million of general fund and put it into the wonderful flexible housing subsidy pool that is going on in Los Angeles, paying for the Star apartments and other places. And with that, he was able to create a pool of funds that can go directly for local operating subsidies, and that what we in Mercy Housing can now use as a proven source of ongoing funding. And this is where the real opportunity for all of you is. Because those of you who are bold and are ready for this new influx of funds, and they're going to be more coming down the pike, with the 1115 waiver and the whole person care and the health homes and other things that Senator Mitchell is trying to do and legislative end of things, there's going to be new money coming down for housing. How are you going to spend that in an efficient, effective way? Who's going to be the bold one in the audience? Who's going to figure this out? What we did in Mercy Housing is a little bit, and we're still trying. It's not working out so great. I'm not going to say it's the world's greatest idea because it's hard out there to do housing development, I've learned as a physician. So what we did is we got an equity partner with a philanthropy that gave us a chunk of change, and we went out and bought a 180-unit building, or in the midst of trying to buy this building. We hope to find other out-of-favor properties, and then we go to a regular retail bank and get a loan. And then with the money that the Los Angeles Health Department will pay, at about $1,800 a month, we can both pay the loan and get the equity partner out within 5 or 6 years, and then take that equity and go to another building and do it over and over again. That's the theory. We haven't absolutely done it. But we don't really care where the payer can be. It can be Department of Human Health Services, or it can be HUD-VASH, which is actually paying a higher rate. And what killed this project, or is making this project hard, is that the health department in San Francisco isn't really coming up to the rate that if they would go to like $1,300 a month, 130% of FMR, then we'd be able to make the deal, but they're not going. And that's crazy to me, because a $1,000 a pill for hepatitis C treatment is so much not useful. Why are we nickel and diming our costs for rental subsidies? If they would just go a little bit higher, then we could buy another hotel or another nursing home and expand housing stock. It doesn't do enough just to take or compete for apartments that other low-income populations can get, right? So what else is going on in the housing subsidy pool is they can get more and more units, but then a poor Latina family with 3 kids who mom is working 2 jobs just to be able to make the rent is not going to have a place to live because the health department just bought that apartment from them. So we need to increase the housing stock, and this is a strategy to do it with what we call our accelerator model. And I am now well out of my league in trying to understand housing finance, and I apologize. But this is as much as I got. I'm going to start talking about tranches in a moment, that I'm really going to get confused. Anyway, this is a picture of the building from Google Earth. It's not too bad, it's all right. It's housing. It's got a pool. I kind of freaked out when it had a pool. I'm like, no way, man. People are going to be having parties and like face down. Are there overdoses in the pool? It's all right. All right, so should the healthcare system pay for housing? And I think this is really where the advocacy opportunity is. When you talk about the work you do or the work I do with homeless people, people want to find a solution. We're embarrassed by where this country has gone, and we should be. There are people who are sleeping on the streets who are suffering intensely in the richest country in the world. We have no excuses. So should we be paying for housing? Well, we got to find a way to make this work. And another big data point that's come down recently is that half of the people who are homeless in this country are over the age of 50. Think about that for a moment. Think about how hard it is to be homeless. And think about how hard it is to be old. And try to do both at the same time. It ain't easy. People are suffering intensely right now in this country. We have no excuses. And the population is only getting older. In San Francisco, the age of the homeless population is increasing almost 1 year every year. So when I started doing this work about 15 years ago, the average age of homeless people in San Francisco is about 38. Now it's 51. We have to take care of our own. No matter what ideas you have about drug users or people who make bad choices, as people age, we have a responsibility to care for them. And every other culture, in whatever our culture is, our complicated mix of cultures, but many other cultures in the world understand that taking care of old people is absolutely a responsibility. But it's not easy. So should the healthcare system pay for housing? Well, I think it's not easy, but it's also not as hard, perhaps, as surviving on Mars.
In the face of overwhelming odds, I'm left with only one option. I'm gonna have to science the shit out of this.
Hardly worth it. So the point being, this is hard work. But you have to reach out to the folks who are in the healthcare sector. You have to figure out your tranches and your 4% and your 9%. And you have to figure out how to get your equity partners in there and then get them out in the time period that it makes them want to go. All these things that you guys are experts in that I am not. But I have spoken to a lot of healthcare audiences, and I really don't get a lot of purchase. You know, they're like, I got 5 patients to see every hour, and I have to get my HEDIS numbers up or I'm not going to get my bonus from Medicare. They are not listening. You guys have the skills to make this happen. You can be, I wouldn't say it's the tail wagging the dog so much. You can get out there to the healthcare system and say, I got what you want. I can make this happen, but you got to work all the details. And here in Sacramento, it might be different than in San Diego, and it might be different than in Napa or in San Francisco, where there isn't a full risk healthcare system and so on. Know your healthcare partners. Get out, make those relationships. Walk across town and sit down and say, I'm going to be building this new affordable development. How about 10% of the units go towards the highest users of the healthcare system, like we did the Half Moon Bay build out with MidPenn and in San Mateo County. We can do this. So, conclusions. First, you got to make the case. Well, how do you make the case? Well, housing is a human right. Nah, not such a strong case. It's what gets me up in the morning. It's what I believe in. It's what my father came to this country for. But it isn't changing policy. We have to have a stronger argument, I believe. And a second argument is that we can create a more efficient system. The healthcare system is incredibly wasteful. So much is done that isn't necessary. Housing can create an efficiency that many people who perhaps are more to the right of me politically will really embrace as an opportunity to improve outcomes for the people who we are here to serve. And then another idea is this concept of entropy. So entropy is, a physics term about that nature hates living in a place where there's so much energy that's being controlled by a lot of things sort of propping it up, and it much prefers to sort of spread the energy out. I think we are working way too hard to avoid housing homeless people. We have this whole sector in place to keep people where they are, to spend huge amounts of money on pharmaceuticals, and I think it's a very artificial system. So I believe that the energy forces, these sort of force be with you things, are going to make it better so that the energy will dissipate. Again, getting back to the first thing I started with, targeting. Homeless people are heterogeneous, and we must target housing from the healthcare sector towards the people who are sick. Eyes on the prize. It's not good enough just to rent more units, even if you have a local operating subsidy pool. We need to increase the number of units that are available to all low-income people, either by finally funding HUD at the rates that they should, which would be awesome, right? You know, HUD is funded 1/5 of the rate it was in 1970, and our population has doubled. So you wonder why your work is so hard, right? But we can't change Congress necessarily. We can't vote in Iowa. We can only vote here. And unfortunately, our California vote isn't changing Congress very much. So we have to keep our eyes on the prize and use what we can spend, which in this case I think is healthcare dollars, to expand housing stock. Now, there are 3 ways we can do this. The way we did it in San Francisco is basically show me the money way, right? You just have politicians say homelessness is bad, I'm gonna write a check, it goes to local operating subsidy. Same thing with Section 8 or HUD, VASH. It's just, expenditure. And that's why homelessness in Salt Lake and Minneapolis and Phoenix and New Orleans and the state of Virginia and the state of Connecticut for veterans is ended, because HUD brought money with the VA to put the money where it needs to be. We can't do that indefinitely. We need to find a way to make it more efficient. So another way is this fungibility way that Dr. Katz has done. More money is coming in, and we have, as I said, these waivers, 1115 waiver, whole person care. Know these things. Own them. Take them. Get the money in from the outside sources, free up county funds, and use it for housing. And then lastly, there is no regulation or law in the federal government that prohibits Medicaid being used directly for rental subsidies. It's not there. There is no reason why this president couldn't, before he leaves office, flip a switch and tell Centers for Medicaid and Medicare to start spending money directly for rental subsidies or development costs to reduce healthcare costs and improve outcomes. We can do that. It's a political thing that we don't have to depend on the constipated Congress to get stuff done. It's an administrative change. And I just don't understand why this president, who I feel so proud to have worked for, isn't flipping that switch. It's something we can do. And the next time when the state of Washington requests to Centers for Medicaid and Medicare to ask to approve their waiver to use housing, as New York State has done and was denied to use healthcare dollars for housing, as California did and was denied, now Washington State is asking, why don't these say yes? I don't have an answer, but you guys are out here, so many of you. Change the discussion. Make it so that Medicaid can be used directly for housing subsidies. And then work the problem. It's not easy, but I have great faith in this incredible energy in this room today. I believe you can go out and you can make these things happen. You can find a way so you're not so afraid to invest in housing that you have to have an out. This is something I don't really understand in the housing development world, why you have to always make sure you can get your money out if the building doesn't work. Well, maybe that you're too risk averse. I don't know. But that's one of the things that makes the deal we're doing in Los Angeles challenging, right? Is because they're afraid that the local operating subsidy pool will disappear one day. And if it does, then are they going to be able to sell it and recoup their money? I don't know. That's not my field. But why are we so afraid when the healthcare system is only getting bigger? So, it's our time. The next 5 years, there's going to be a lot of money coming down from the healthcare sector for housing. Who's going to be out there ready to get it? Who's going back to their agencies and are going to figure it out? Who's going to be able to get the lowest price, the best quality, and make the difference for the people who need it the most? Who's going to be the one who's going to work the system to give the people who are suffering the most a voice? I think it's you and you and you, and I think you can do it, and I really look forward to hearing the story. So thanks a lot.